Welcome everyone to our live chat today. Our topic will be focusing on how volunteers can support staff and patients on COVID wards. So we've got two people who have signed up to share with us their experience. The first one, if we could ask Joe Crooks from Jersey and Westminster NHS Trust. Joe, would you like to speak?
So I guess just to bring you up to speed with where we are now, we have 14, that's 14 volunteers who have delivered some kind of volunteering on one of our COVID-19 positive wards. And to date, they've delivered around 60 hours of volunteering across those wards over the last 2 weeks. So that's where we are now. In terms of where we've come from with all of this, we started, as I think many other trusts did in this crisis, with a lot of our existing volunteers pausing their volunteering and standing down. So what that meant is that we had a very established ward helper program, which immediately fell by the wayside, really, as so many left. We only, in reality, had around 25 volunteers left from a really large group of people. Then set against that the fact that daily, indeed sometimes several times a day, wards were having to change and be reconfigured to respond to the crisis. So wards were, cases were either popping up on wards, or wards were being reconfigured and were being reserved for the treatment of COVID-19 or not for the treatment of COVID-19. So it was a rapidly evolving situation. At that point, we made the decision to pull all of our volunteers from the wards because we didn't feel that we could keep them deployed there in a safe way. So instead, what we did was we recruited in very short order over 100 new volunteers from members of the public. Indeed, the first volunteers we managed to turn around in under 2 weeks from that initial application stage, which is very, very quick for us. We've not done that before. So what we had was a lot of new volunteers, and we didn't deploy them into ward helpers. Instead, we got them to do a regular runner role. Lots of things that were needing to be run around the hospitals, and that was a way for us to deploy volunteers in a relatively low risk way, in a way that was going to be really, really helpful for our 2 hospital sites. That's been working really well, and volunteers have been really, really good in stepping up to that. Another thing that we did very early on in the crisis is commandeer 2 rooms, one at each site, which were going to act as volunteering hubs, so that volunteers had to kind of come and check in with us. I know some other trusts have hubs already, but we didn't. We were operating out of 2 quite small offices until the crisis. And what that allowed us to do was, again, from a safety perspective, make sure that volunteers were checking in with us, that we could cover any briefings with them, because the situation was changing quite rapidly. It allowed us to mitigate some of that risk. We also had some staff members from other corporate functions being redeployed into our team. So they were helping us really upscale our work very quickly and to turn around those applications. So that's I guess the background. What we found was, as I'm sure others have found, was that with the fact that we weren't allowing visitors onto the ward, onto any wards, that we had clearly a lot of patients who were really fed up, lonely, and we had a lot of overwhelmed staff as well. So what we decided to do is that we needed to ask the question as to, is it going to be possible for us to deploy volunteers onto COVID-19 positive wards? And so we looked at what the risk was involved in that, and we conducted a thorough risk assessment that was focused on, key things around what the PPE requirements would be, what tasks they'd be carrying out, what training might be required. And that risk assessment was carried out with the clinical leads, so the nurse who's leading on the PPE, as well as heads of infection risk and control, those types of people. With that risk assessment in place, that's really where that's kind of where all of our other processes and documents spun out from. We decided that it would be possible to deploy volunteers in a way that was not putting them in any undue risk onto COVID wards. So what I did was I visited one of the COVID-19 positive wards and worked with the ward manager there, who I was used to working with from before the crisis, on a more limited role. So it wasn't our regular ward helper role. It contained many of the same features, but was scaled back and scoped out so safer to operate.
Oh, sorry, Joe. It's just there's someone in your background. Is that right? Because we can hear some background noises. Is there someone?
Oh, sorry about that. I think someone's making a phone call. Sorry, I didn't realise that the background noise would be so loud. Just a moment.
So sorry, everyone. I'm sure Joe will be happy to repeat some of his points earlier. Just give us a second.
All right then, that's okay.
Just a moment.
Oh, thank you.
Sorry, Steph. Background noise is really loud on this webinar, so they can hear you as I'm talking. Is that right? Thanks. Thank you. Sorry about that, everybody.
Do you mind just repeat a few points earlier, just about?
Yeah, of course. So what we conducted was a thorough risk assessment with the clinical leads in that, so the lead nurse on PPE and the heads of infection risk and control. That risk assessment was the starting point for us about how we might do that, about what training we'd need in place, about what documentation we'd need in place, but the risk assessment was the start of it. So we came to the conclusion that we could do it safely. I visited one of the COVID-19 positive wards and drafted in dialogue with the ward team there, a limited ward volunteering role that we felt was going to allow volunteers to operate safely, and really got the ward team on board. Other key documents that we created was so the new role description, which was a more limited role, a new ward handbook, which was really covering some important aspects such as PPE and where to report to, and an enhanced volunteering agreement. So we have a volunteering agreement for just normally, but an enhanced one which was really spelling out the fact that it would be deployment onto a COVID-19 positive ward. We also developed a short briefing that we deliver to any volunteers who are going to one of our green zone wards, be that COVID-19 or not. And so we take all of the volunteers through that as well. Volunteers have to attend that briefing. They have to sign the right documents and obviously make sure that they read and understand what they're going to be doing. They then go for an initial shift where they're shadowing an existing and more experienced volunteer, so they can properly understand how PPE is working, areas where they should and shouldn't go. What I should say and emphasize is that I don't know how other trusts are working it, but we do not deploy volunteers onto red zones. All right. So what we do not have is volunteers on ICU. We don't have volunteers deployed into areas where they are doing aerosol generating procedures. So where you would require, the full PPE, the kind of stuff you might see in the news. We certainly don't have volunteers walking around in hazmat suits or anything like that. They are deployed onto green zone wards. Some of those green zone wards are COVID-19 wards and some of them are non-COVID-19, but the same PPE rules apply. So that is, blue surgical mask, it's gloves and it's an apron for if you're going within 2 meters of a patient. So that's really how it's working. What we are finding now is that thankfully, the numbers of wards being dedicated to treating people with COVID-19 is shrinking. And so we're trying to hit a moving target to a certain extent. And that's been always a challenge about this role, is that we've never been quite sure where we can deploy to and where we can't. But we're definitely seeing now more wards return to normal. The streamlined recruitment process really helped. And what we found is that our initial idea was, if we were going to deploy volunteers onto COVID wards, is that we should go to those volunteers who are already experienced as ward helpers. Actually, what we found was, in practice, is that many of those guys hadn't been at the hospital for a few weeks and were not willing to, or were not psychologically prepared for being in COVID-19 positive wards. Whereas actually the people who have responded best to this are the people who have been fulfilling runner roles at the trust, because they're used to being in the hospital as it is at the moment, and they've been more willing to step in to the ward helper roles, which is really good actually, because the runner role is starting to decline as the hospital begins to return to something approaching normal. There's more I could say, but I don't want to go on for too long, so I hope that's been helpful.
Thanks so much, Joe. I think it is absolutely amazing. It's really helpful. Just to let everyone know, you can raise your hands if you want to ask Joe questions now. You can put in the Q&A box. So we've got a couple of questions for you, Joe. Jessica, she asked if you could share specifics about the limited war role descriptions. I think you did share with us some role descriptions.
Yeah, that's right. Yeah, I'd be happy to share that as well and pass it on. On one site, it's more of just literally a mealtime buddy role, so incredibly pared back. And on another site, it's helping out during a mealtime. So we're centering things around mealtimes because, taking trays and giving them out to patients we're trying to keep things really simple because it's hard enough and stressful enough for people to be on a ward anyway at the moment with the PPE and all the rest of it. I don't know if anyone's had to wear PPE for any length of time, but it's not very comfortable. And you're having to exercise a lot of your brain power just focusing on doing the right thing and exercising good hygiene. That what we didn't want was a really complex role that was going to be on top of that as well. So it's centered around helping out during meal times, getting the trays of food out to people, and actually then spending a bit of time with them during the meal. So what we would usually have had is with the ward helper role, you might have someone playing a game of chess with a patient or, talking and reminiscing for half an hour, 45 minutes or an hour. In the current circumstances, that's just not appropriate. So we are saying to volunteers, please do, stop and have a chat with some patients because that's what they want. They want to have a chat. But really, in reality, those interactions are relatively fleeting. It could be 5-10 minutes at the very most. What we don't advocate is that our volunteers should be sitting down and having lengthy conversations with people.
Perfect. Thank you so much, Joe. And just so everyone know, you can go on the Learning Zone and look at the COVID resources where we post all of the role descriptions there. The next question we have is from Jen. So Joe, are the colours of green, amber and blue all standard across the NHS?
Honestly, I couldn't tell you. We use green, red and blue, but I don't know what other people are doing. Sorry, are you getting some background noise again?
Sorry.
Sorry, guys. If you can just step the other side of the doors, thanks. Sorry, we run a volunteering hub here as well. I had tried to find another office, but anyway, long story, which I won't bore you with. That's what our trust uses. I can't speak to other trusts.
Okay, thank you. So next one from Laura is a bit similar. So, hi Joe, hospitals are divided into red and green zones. On red zones, whether ITU or wards contain COVID positive patients, those in green zones are tested as negative at time of admission. So I think that's just a statement from Laura. The next one from Gillian. Gillian is just saying that this is very interesting to see new ward handbook. Sounds great and very reassuring for ward staff. Would you be able to share the new ward handbook?
Yeah, it would be a pleasure.
Perfect, thank you. Laura, just want to confirm, can you confirm your volunteers are in green zones only, i.e. confirm COVID negative on admission? Thanks.
Our volunteers are in green zones only. They don't operate in red zones.
Yeah, so is that green zone or they still have COVID-19 patients?
Yes, so for example, we have a ward that is a green zone that is being used to treat COVID-19 positive patients. So it has been dedicated only to treat COVID-19 positive patients, right? But what they are not doing on that board is, I guess, what you could call intensive care. What they're not doing is aerosol generating procedures. So call them AGPs. I know I've had to learn this kind of lingo recently as well. And I'm not a clinician, but what I understand it to be is that there are some procedures that basically cause more matter to be brought up from the lungs. Okay, so there are lots of things that would cause. So if you're ventilating someone, for example, that is potentially an aerosol generating procedure. So the wards where our volunteers are, people are not on ventilators. They're not the types, again, the kind of things that you're seeing in the news. They are not on ventilators. For all intents and purposes, they look like regular patients. They are clearly poorly, but they have, and they have a really bad virus, but but they look like regular patients.
Yeah, makes sense. Thanks so much, Joe. The next one is from Kerry. Had Chelsea and Westminster introduced a no visitor policy too, and how well staffed are your wards, and are volunteers well utilised?
I know what policy, sorry?
No visitor policy.
Correct, yeah. So we have a no visitor policy as well. Staffing is much better than it was. It was, as I think happened with a lot of trusts, it was really bad around a month ago or so, but staffing levels are much better than what they were now. So again, this goes back to this constantly moving targets, in that we started the planning of this and the risk assessing it probably 5 or 6 weeks ago, and that was in a very different scenario. And you may remember, I think for a lot of trusts, including us, people weren't really sure if at that point whether the NHS was going to be overwhelmed. We didn't know. And so what we were trying to do is move as quickly as possible. Thank goodness the NHS turned out not to be overwhelmed, and it hasn't been yet, but it meant that when we were looking at original deployment, staffing levels were at a much lower level and were under much more strain than what is the situation now.
Yeah, perfect. We just see that Max has raised her hand to ask questions. Just give me a second. Max, would you like to speak?
Yeah. Hi there. Hi, Joe. I just wondered if you're getting any feedback from the volunteers that are on the wards, how they're finding it, what they're feeling about being on there, and that sort of thing.
That's a really good question. This has been the really beneficial aspect about having the volunteering hubs in place. So they have to, it's mandatory that they have to check in with us before their shift starts and when it finishes, so that we can really get some feedback from them. As well, it's been helpful having them buddied up with an experienced volunteer who can, flag with us if they have any concerns. On the whole, our volunteers have actually reported feeling, I know this sounds quite strange, kind of reassured once they've been up to a COVID-19 positive ward. Personally speaking, that's how I felt as well. I think to a certain extent that if we just follow the news, then we potentially think that hospitals just look like war zones at the moment, and that everything looks like frontline intensive care units, whereas actually it's been very reassuring for volunteers to go up towards and seeing that things are relatively quiet. Many of these patients are getting better and will soon be discharged. And I think where people have been feeling an element of stress is chiefly it's around PPE. And that's really where it's important to make sure that they've got that briefing beforehand. And I don't know about anyone else, but I keep needing to be reminded about what order I doff and don in, the odd time that I have to do it. And so it's making sure that we are deploying into wards where they have supportive nursing teams, and that's been really good for them.
Perfect. Thanks so much, Joe. We got a lot of questions from Lisa here. Lisa, she's from NHS Scotland. So have your volunteers been supporting C19 patients with virtual visiting, for example, helping patients connect with loved one, using tech support with smartphones or iPads?
Yeah, good question. Yes, that's one of the main reasons why we wanted to deploy onto one of the wards, a couple of the wards in particular, is that they do have iPads on a couple of they have them in all of the wards now, but we are piloting using that to help patients to call or FaceTime loved ones. To date, it hasn't worked very well. One reason is the tech. As we know, the NHS is not necessarily the best at tech, so they are trying to get these tablets to work. They were kind of put onto the wards, but the nursing teams here weren't given lots and lots of training on necessarily how to do it, and they haven't had a lot of time to really even look at it. So our volunteers are working to try and overcome the technical hurdles to it. What they've also found is, so one of the key COVID wards that we deployed volunteers onto is a very elderly ward. So most of the patients are in their 70s and 80s, and they just don't want to FaceTime. They don't really understand it. Look, my gran loves FaceTiming, but I know there's a lot of people who just aren't up for it. So where that has happened, they've been helping them to make phone calls to loved ones.
I see. The next one we got is from Joseph. Were there any elements of regular recruitment that were delivered differently or not delivered through the streamlined recruitment process?
So if I understand that correctly, all of the volunteers that we have newly recruited went through a streamlined recruitment process. And I think you guys have covered that in some of your other seminars, right? Webinars where you've been talking about how that's worked. We exercised a streamlined recruitment process here as well. And that's how we've done it. What we did recognize is because that this role requires, it carries more risk and it requires more support, is that that's where we did have an additional kind of briefing that's allowed us to capture bits and pieces that a streamlined application process wouldn't have allowed for.
Joe, you unmuting yourself. Joe, can you still hear us? Give me.
Can you hear me now?
Yes, we can hear you now.
Okay, sorry, did you hear that response, or do you want me to say it again?
No, that's fine, yes.
Okay.
Next one we just got one is from Joseph as well. So were there any restrictions on who could or could not volunteer on your green walls?
We followed Public Health England guidelines on that. So it's anybody's in those high risk categories. So I don't know, they change, but yeah, we wouldn't have anybody who's one of those high risk COVID-19 groups on the ward.
Definitely.
I should also say that until now, at least, we've also said no under 18s. So we have a youth volunteering program and we have young volunteers who are under 18 performing other roles. But at the moment, at least, we are not deploying under 18s onto COVID-19 wards. I know the science says that the younger you are, the less at risk you are, but it's about a safe operating environment.
Definitely. And then another one from Philippa, are volunteers on COVID wards signing disclaimers?
They sign a slightly tweaked volunteering agreement, which spells out that they're going to be deployed onto COVID-19 wards. In reality, the agreement looks a lot like the one that we use for everybody, but it has a few additional clauses.
Of course, thank you. Next one from Amanda. Were your volunteers able to get to you without using public transport?
A lot do live locally, but some do use public transport.
Yeah, it's quite a bit of a risk, isn't it? Joe, so there's another question actually is coming from me. I'm always interested. So obviously this kind of practice there's a lot of risk in that. How did you manage to persuade your executives, actually like chief nurse, that they agree to have volunteers on the wards? Was it difficult?
To be honest with you, a lot of the momentum for this came from the nursing teams. It wasn't, the push wasn't from us saying we really want to get volunteers onto COVID-19 wards. It was, senior nurses saying, we have patients on these wards who have no visitors. We aren't saying that we want you in red zones, but we are seeing that we have a feeling that we can do this in a safe way. We know that volunteers have always brought a lot to the ward environment. And so can we have a conversation around how we do that? So that momentum came from the nursing team rather than from us. And then we worked with them to make sure that, our duty of care primarily as a volunteering services team is to our volunteers. So we were being hyper sensitive to it. I'm not saying nursing, gung ho about this, far from it. But I think if anything, it was us who were being the most reluctant out of anybody.
It actually works well, so I think your nursing team would make a very good decision there. Just want to check if you think like after this COVID-19, what will be the practice that you will keep going? You will keep using it.
I think what's really good about this is that I feel like now we have like a model for, none of us wants this to happen again, but if there's a second wave, or perish thought, if there's another pandemic that comes, obviously all viruses are different, but what we have, I suppose, is a working template for how we can do this, in a safe way. I think in many respects, we're all looking at what a new normal is going to look like, because in reality, we don't want to go back to the way things were actually. We've embraced, it's been difficult, but we've embraced and innovated, and we've embraced a lot of new working practices. I think what has worked best that we would want to carry forward into a post-crisis transition is having a volunteering hub that everybody can check in and out of, because it helps you kind of pick up issues and concerns as they happen. So it makes you much more kind of responsive and proactive team. The use of senior volunteers. We've always had senior volunteers, but they played a much more prominent role in helping us to onboard those volunteers, and were much more being able to shadow an existing volunteer who can show you how things work, who can kind of calm me down a little bit. Look, I won't deny, I myself felt pangs of anxiety going onto a COVID ward for the first time. I don't think you'd be human if you didn't feel like that, you know. And so having someone who can take you through it in a calm way was really helpful. I think that we've shown that you can, as a service, we can recruit far quicker and effectively than we perhaps gave ourselves credit for as well. So yeah, I think that's probably what we take from it.
Perfect. Thanks so much, Joe. Aria, so we've got loads more questions for you, but we'll come back in a bit later because we would like to ask Emma to just share her experience as well. Is that all right with you, Joe? We can come back with you in a bit. With more
No problem.
Perfect. Thank you. And Emma, would you like to speak now?
Hello.
There you go. Hi, Emma.
Hello. So ours is relatively similar. There's a few different things we've done slightly differently. We've got 37 people on the wards at the moment. They vary from COVID positive, COVID negative, and COVID suspected wards. They're on all wards. We have tried a volunteer in ITU. They were more helping on the buzzer and things like that, but actually they weren't required, and the volunteer found they were wasting, you know, their time. They were better used elsewhere. The thing that we have found is we've got a really good service with helping with video calls. We do a letter to loved one service, which we've now increased to having the letters read out to patients. Volunteers do an array of things, including feeding, sitting with patients, giving them hand massages and things, having meaningful conversation. They make beds. They do quite a lot of roles that they did prior to COVID. So we haven't seen much change in that. And the stance that we've taken on it, and these people, they've all gone through occupational health. So we all know that they're fit and healthy to go onto the wards, and that they're adults at the end of the day, and they have a choice. And if they're choosing to go onto the COVID ward and they understand the risks which are told to them on numerous occasions, then they're happy to go on. I'd say we are operating out of a hub as well. The only thing that we've done differently is if the volunteer is going on to a ward, we don't have them back in the hub. Our infection prevention said to us to mitigate more spread of risk, they report to their ward, they change there, and then they, you know, change to go home. But we have once or twice weekly contact with the volunteer to make sure they're okay.
Thank you.
So I don't know what kinds of things you want to me to cover. We did a big recruitment drive for it.
Yeah. But just before we go into that, Emma, would you just introduce yourself a little bit? Everyone has been asking, and obviously they want to know a bit more about you.
Sorry, can you say that again? Sorry.
Sorry. It's just everyone has been asking where you're based and what you do. So.
Yeah, sorry. So I'm head of volunteer services. I've also got my coordinator on the line in another room. So that's Matthew Collins, and we're from Northampton General Hospital.
Perfect. Thanks so much. Sorry, everyone. My fault as well. So we got just a question here for you, Emma, from Wendy. With the letters to loved one being read out to patients by volunteers, were there any issues around sensitive information which had to be considered or dealt with?
So like all of our volunteers, they all have to sign their information governance agreement, and they've all had to do the mandatory training as standard, which we've obviously slightly tweaked. The letters are read out, so you know we read the letters because you know it's hard not to read the letters. We do a dictate service as well, so the elderly obviously don't have access to email, can ring through, and their volunteer will then type the letter out for them, what they've dictated. So there hasn't been any sensitive information. I think Matt will agree. There's been some really, really funny letters that have made us laugh, that you can really see the humour from these people. But touch wood, so far we haven't. We also print them in very, very big font. So if the person is conscious, then the letter can be read by themselves. The volunteers have been so touched by that, the video calls and every interaction they've had with their patients, that it's been amazing to see.
Do you have the same problem that Joe had with the technology? Did that happen with you as well?
Yeah, so I think Matt will probably be laughing. There was one day it took us 6 hours to get there. We had a patient on one ward and his husband was on another ward. Both of them were really poorly and we could not get technology to work. It took 6 hours. We've now got the devices that we have teams of people who probably conduct 15, 16 calls a day. The wards do have their own devices, but we've been donated other ones from our charity that we know work. We do the booking line for our relative helpline. We've taken full control of it. So we test the line by ringing the relative prior to doing the call, so the relative isn't upset if it doesn't work. The volunteer will either go into the ward and do the call, and sometimes they've had to hold it, or sometimes they will leave the device. So if it's in ITU, the device will be left at the door, and then obviously Clinell wiped down and taken back to the next call.
Thank you. So we have a question here from Amanda. Do you offer this role to existing volunteers first and then advertise to new volunteers? If so, what was the uptake from existing volunteers?
Okay, so we originally had 302 volunteers, and a lot of those fell into the over 70 category. I'd say 50% of those fell into that category or were vulnerable with underlying health conditions. So we've kept our younger group, so I would say our 16 to 25-year-olds, and actually we've seen them in every day. So the younger people, unfortunately, who are a bit more tech savvy, have taken on that role, but it has been a mixture of new volunteers and old volunteers. But we've also introduced things like we've got a local company who do who dress up as princesses. So we have that to the children's ward. The volunteer will have the princess on standby, so we have a day, and then they'll go into paediatrics and do it. So the volunteers did fight over the princesses and Spider-Man to begin with, but it's those things that are enhancing the patient experience as best we possibly can.
That is amazing. Do you have some stories like that share on your social media that we can?
Yeah, definitely. We do keep going. Obviously, with Twitter and things like that. But yeah, we can always share and take the pictures, especially of Spider-Man and the princess. I'm sure they'd love that.
I'm sure I will love that. And we have a next question here from Gazelle. Did the volunteers come through the Good Sam drive or your own recruitment campaigns?
So we went quite quick on it. We took a gamble, and we already had an active advert on, but we had probably the best part of, I think I personally FaceTime interviewed 150 people, but we went with our own advertising. We have really good coverage with our local newspaper and our radio station. We've got them on side as such. Our communications team are amazing, and we've quite a good following on Twitter and word of mouth, the local school connections, and also we're very fortunate we have a lot of community support. So when we do fundraising events and things like that, they help share the things for us. We're in a really fortunate position, but again, that's come with a lot of prep prior to COVID. So I don't think this is, if we weren't where we were before COVID, we wouldn't have achieved half as much as what we have.
Yes, I understand. I think that's quite a common problem for a lot of trusts, really, to make things go really fast. We have another question from Julian here. What is the kit? I think what she meant, what did you use to support volunteers and patients?
Sorry, can you just?
I think Julian, did you mean that what sort of equipment that the volunteers use to support patients? So no, did you use iPads or you use tablets?
Matt's your best person to ask for that one, because he actually leads on the video calls with people. So hopefully he can raise his hand and he can speak.
Okay, so for the video calls, we have 2 Livaro tablets, which we take out to each of the wards to do the video calls. We also have a mobile phone as well, just in case the video call doesn't work, and they may want to change that to a phone call. So we do have those different devices to take out to the wards.
Perfect. Thank you so much. I think this is a question for both trusts here. Have your volunteers got tested for COVID-19?
Yeah, so we have had a couple, and they've both come back negative, but again, they've been treated exactly as staff would. So I know that's quite an important thing. And what I really want to reiterate is the support that's been put in place for our volunteers, because this is like unprecedented times. And you know, people put their hand up and say, I want to go on a COVID ward, but actually, how do we know how they react? So we've made sure that they've got the right support in place. We've given them the same support that a member of staff would have, so they have access to the same counselling lines, the same in-house SOS services that they have. They can go to the same open space and see our practice and development team and debrief. I've got a mental health first aider on my team. So as well as getting tested, I needed to make sure that they had the emotional and well-being support, because I think that's actually paramount in any volunteering role, but particularly at this time. So I forgot to mention that, but we have got the poster. I think I can send it over. I think I've already sent it over about what support our volunteers do have available to them.
Yes, I think so. Yes, you have. Another question from Gillian. Does mobile phone need to be a smartphone? Was that just a
yeah, it will need to be a smartphone, because we find actually WhatsApp works best. I trust it's going to be different with the Wi-Fi, because obviously each trust blocks different things, but our IT support have sorted out the bandwidth on our devices for us, which allows us to facilitate WhatsApp calls. I know Matthew's managed to do sort of 3-way calls on FaceTime if we've used the iPad, but again, it's just a hurdle that we've come across, and we're quite a headstrong group of people that we always overcome what barriers we seem to face.
Well, that is the right thing, right? Skills to have.
Yeah.
And then the next one from Joseph. Did you arrange online training for new volunteers? And if so, did you use the existing NHSE volunteers passport or your own online training?
So all of our volunteers have to undertake normally face-to-face training, but our training and development team put together a bespoke package for our volunteers, which to be fair is very similar to what they were using to onboard healthcare assistants, the same level to make sure, you know, they've got their safeguarding, RAP, prevent, infection prevention. So they had to do that and undertake all of the tests prior to coming in. In addition to that, all volunteers, I know I've mentioned this before, had to go on the basic life support training. So that was one of the things that came up in the risk assessment. They had to go on that training, and also every volunteer who went on to the ward, including the existing volunteers, had to go on the new COVID-19 ward-based training, because it had an element of you know, how you feed slightly different, how the PPE works. So yeah, every volunteer had to be signed off on all training prior to starting.
Perfect. Thank you so much, Emma. So the questions. So I haven't seen any more questions for Emma or Joe, but do keep sending coming in. Thanks so much, Emma. And we just got Martina here who would like to share her experience as well. Martina, would you like to speak?
Hello, can you hear me?
Yes, we can hear you.
At last, because there's been so many difficulties trying to get that done. So I'm the volunteer manager of the Belfast Health and Social Care Trust. Quite a large trust. There's 22,000 employees in the Belfast Trust. And what I want to share is our experience in terms of the medical students And it's not so much related to this here about going on to COVID-19, because that's something we're still in negotiation with, but we're about to start a role with all of the medical students. Belfast would have the main universities for the medical students for the whole of the north of Ireland. So that would be Queen's University and the University of Ulster. And so when all of this emergency happened, we were approached by the university about utilising with their medical students. Now, we obviously had to negotiate with that, not final year, because final years obviously have gone on as graduates to go in early into the system, but looking at first to third years with that. And what we had to do then was to do a role description, and parallel with that, look at issues such as the access, we call them access, and the occupational health, and look at how those could be fast tracked. What we found there was, obviously there's a lot of bureaucratic and technical issues in trying to get the students and getting them onboarding. So we looked at getting a particular special hub done, and that was with the volunteer now organisation used with know and work closely with as Helpforce here in Northern Ireland. So they created a special hub for the medical students, and that once the role was defined, agreed, and obviously passed our trade unions, all of the roles we've had to stand down, and each new role created has to go past all of the trade unions and get approval. And I'm sure that's maybe similar other parts across the water, but that's what has to happen here. And that can take a very short time, maybe of a turnaround of a couple of days, can maybe take much longer if there's particular issues. So that's what was set up. And then when the role is put on, all of the medical students at Queen's will have access to it. There'll be not a coordinator, but a facilitator from the university end. And then they would apply to that and use the contact details of the particular person on it, to our coordinator, volunteer coordinator on it, to contact, and then that whole process has just been described by Joe and the other speakers would happen. Now, what's happened is there's been a bit of a delay just for some, not on our side, but other side issues. And we have still to do some more negotiation with the trade unions, but we have not them deployed onto the COVID-19 with wards, because we're looking at this coloured zones, etc., with this at the moment. But we'd like to see what does happen from it. And as time has shown here in the north of Ireland, there has been much less, thank goodness, of a requirement and need in terms of the hospital take-ups than certainly in other parts, particularly in England. So we're re-looking at it. But as again Joe had said, we're looking at the maybe second phase and how we can take the learning from this, even if it doesn't totally happen, to the next phase with that. That might happen maybe later on in the year or with another pandemic. So this is a very unique one. We'll see if it goes into with the other wards and zones. We're looking at that, but certainly they're deployed as those ward helpers, as those support in the non-COVID-19, which would be at our Belfast Nightingale Hospital and our other main hospitals here in Belfast. So that's the situation, and we'll keep you updated, of course, Sally. In fact, as soon as we get something and we get it through, with that, volunteer now are still doing some work on this, and they're to get it back to us. But as soon as it is, I'm happy to get through Denise at Volunteer Now and get that role to you. So that would be for medical students. Medical students and healthcare, other healthcare students too, because you've got maybe the OTs, you've got the physiotherapists, you've got other ones who could be involved within it. So it's not just within that. Obviously, the medical students are very enthusiastic. They want to get this particular experience. They want to feel part of the movement of having done something during this pandemic. So, but it's getting all those things happening together, and the unions as well, which we have a very good relationship with, and I, in terms of always take on board any constructive feedback from them. Is that helpful?
Yeah, that sounds like a good plan there, Martina.
All right. Okay.
Thank you so much for sharing with us your experience. I think it's actually to the next question from Terry here. It's actually for everyone. So has anyone started to plan how to reintroduce services? Someone? Would anyone want to share their thoughts on this topic? Have you got any thought about the plans for post-COVID-19 yet? Do raise your hands if you wanna share your thoughts. Right. There we go. Emma, would you like to speak?
Yeah, I know it's a little bit random. I know we've all sort of spoken about space and things, but we will be putting in bids to our local charity to get a more permanent location really for a hub, because if we have to return back to our office space, things like our response volunteers, we can't actually function because of the social distancing office space. So one of the things we started to look at is actually when these people come back, having a more sort of suitable hub for us. So our charity are quite supportive of it, us putting forward for the bid. We're just waiting for quotes obviously on buildings, but I think it's just reassuring the volunteers when they come back that, you know, that we will adhere to everything, that the PPE and things will be available if required. But we're not putting any pressure on anyone to come back, because I think an anxious volunteer is ultimately going to end up in a really anxious patient, and then it will have the adverse effect.
Perfect. Thanks so much, Emma. We've got Amanda Bryan here. Amanda, would you like to speak? Amanda, you just need to unmute yourself. Go. Just give me a second. Amanda, you just have to unmute yourself. There we go. Do you want to say something? I'm very sorry. We can't hear you. If Amanda, if you wanna share your thoughts in the Q&A box, then that'd be great. Anyone else would like to share your thoughts on your plan? Okay. Right, so we haven't got anyone else to raise a hand yet, but we still have a few questions for Joe. Joe, would you like to unmute yourself and I can read out the questions for you?
Go for it.
Yes, this question from Sharon.
Yes.
Raised that they cannot visit their therapist, but a volunteer can. So I guess.
Say that again, sorry?
Yes, so it's a question like, if any relatives told you that they cannot revisit the patients, but they want a volunteer to visit the patients instead. Have you ever got that case?
No, we haven't come across that.
And I guess this question, do you have any plan to reintroduce your services?
So, good question. We're doing a lot of transition planning at the moment, and we've got a team strategy day later this month. That's definitely the way things are heading towards transitioning. So, I think what we're anticipating is a transitional phase of at least 6 months to a year, where we've got volunteers who have been inactive, who will want to come back. Some will never want to come back. Plus, we're going to have a lot of new volunteers who will be returning to their jobs, returning to work, who will, they will no longer be able to give their services. So there's going to be this transitional stage, and then obviously it's kind of mapping that along with the trust making decisions on when it starts to open up, elective surgery or outpatients, when it decides to let visitors back in. So clearly, again, this is about a moving target. What we can't do is over-plan, because it's hard to know where we're going to be a month from now. But we are anticipating, we're hoping that we begin to go back to that kind of a new normal that I'm talking about.
Perfect. Thank you so much, Joe. Another question from Carrie here. Have any of these volunteers been taken ill, or they offer testing in the same?
Taken ill, so I don't know of volunteers who have, for example, been taken ill with COVID-19. We offer testing to all volunteers as we offer testing to members of staff. So if they start exhibiting symptoms on their shift, there's a number that they can call and they will be swabbed ideally before they leave for the day. And if they develop symptoms, or if someone that they are living with develops symptoms while they're not at the hospital, then it's important that they don't come in, and they are to either call or email and then are referred to a test.
Perfect. Thank you so much. This question is for you, Joe, and Emma as well. So did you face any resistance from within your trust to have volunteers on COVID positive wards?
Did we face resistance from where, sorry?
From your trust, so within your trust, so maybe your staff, for example, to having volunteers?
I think no. I think because the boundaries were drawn very early on about not going into red zones, that probably helped. I think where the reluctance was as I said, actually amongst some, our team was the most cautious of all, so I was thinking, goodness me, can we do this? If we can, what's our duty of care? So for us, for example, an absolute must to have was the ability to offer testing to our volunteers in the same way that we would offer staff, as we were asking them to do that. And then, of course, there were volunteers who were saying, no, thank you, I don't want to do that. There are volunteers who, I should have said, we deploy into other green zone wards that are non-COVID. So where a volunteer, it's entirely up to them. They are briefed on what the risks are up front, and if they want to go to COVID, then we'll help that. We'll make that happen. And if they prefer non-COVID ward, then we'll do that.
Thank you so much. Emma, would you like to share anything?
I wouldn't say we had any resistance at all, but again, I know I keep harping on about it, but I think that's because the structure was in place prior to COVID. We have an NGH community Facebook page, which has got sort of 2,500 people on, and a nursing midwifery one. So we've got a good following of clinical and non-clinical staff. And everyone was very supportive of making sure that volunteers were treated exactly the same as staff, so the right PPE was available, like it's just been said, make sure the right testing, and that's why I was really making sure that the support was in place before we went on, because if we didn't have what the staff, those fundamental things, then I wasn't prepared to move forward. And we weighed it up, but I think it sounds like we both trusts here. We went quite early with the recruitment and getting people in, which has probably put us in a stronger position now while we are where we are.
Perfect. Thank you so much, Emma. I guess it all depends on the trust culture, isn't it? Some trusts are willing, they're aware of the risk and they put a measure in, but obviously some trusts are very cautious of that. So it's really hard to have one solution for everyone. There's a bit of a comment here, but I wonder if Emma and Joe could share their thoughts on this. It's from it's from Amanda. Yes, I think it's from Amanda. So their trust's biggest concerns is public transport use. So until this improves, they feel if the volunteers are not essential, they shouldn't be encouraging them to get to the trust using public transport. Do you have a similar problem? Do you feel like having volunteers coming in using public transport could be a risk here?
I think that's where it comes to infection prevention, because you look at clinical staff, they're still coming in having to use public transport, but that's why it's very important that our volunteers come in different clothes and they change when they get on site, and then they put those clothes in a bag, change, go home, and those are then washed at 60 degrees when they get home. So we are treating our volunteers as would clinical staff in their uniform, and are being treated, and that's why we moved to the hub, because we've got 3 changing rooms where we are. So no volunteer is allowed to come in on the response, because obviously we see the ones who come on the response. No volunteer is allowed into the hospital wearing their uniform, and they're not allowed out. We'll have to become a bit like the uniform police at ends of shifts and making sure people are going home. And that's exactly the same on the wards. And we've got that relationship with the ward that you know, they would tell us straight away if the volunteer wasn't adhering to their local you know, policy. Is quite important, you know, because one ward might do something differently, because we've got a local sports centre, so some wards are using the sports centre to get change where they don't have changing facilities, so that volunteer would be encouraged to use that sports facility. But some other wards have their own changing facilities, so, you know, the agreement is the ward treats the volunteer as they would a member of staff, and it was all of those things that had to be put in place before the volunteer was allowed to go to the ward. So we had, you know, there was a sort of a two-way thing. Yes, you can have a volunteer, but you need to do A, B, C, and D.
Perfect. Thanks so much. Emma, Joe, do you want to add anything?
Very much the same thing. We're very careful about making sure that volunteers understand about what they wear and taking, you know, not wearing what they would on public transport, so getting changed before and after their shift. We encourage them, where possible, not to use public transport. And I know the government brought out guidelines yesterday on the use of public transport. There's a very handy infographic which we've put up and displayed in our hub as well, about trying to stay safe on public transport as well.
Thanks so much, Joe. So this one is for everyone. I'd be so grateful if you can share your thoughts on this. So Lisa was asking if anyone has volunteer roles supporting the well-being of clinical staff, for example, giving them teas or making coffee, having some time to chat and de-stress on breaks. At the moment, they don't have any volunteers active in COVID-19 areas in NHS Scotland boards, but they're looking at roles where volunteer can support with out of red green areas. Anyone want to share their thoughts? Do you have any volunteer roles support staff?
We do at Chelsea. So we've got volunteers working in the staff wellbeing hubs. So they'll serve tea or coffees to people that want it. They'll make sure that we have at each hospital a dedicated staff wellbeing hub. So that's a place where people can go to chill out. It's got a big TV, you know, it's got tea and coffee on tap and various little goodies. So we make sure that volunteers are on hand to support staff, just to kind of decompress a little bit, make sure that there's plenty of water for them to drink. I'm sure you've heard there's a lot of staff on ICU and they just get so hot and they need so much water. And then recently, as of this week, we started working with the Wingman project, which is run by the airlines. And so that's flight crew who are at the moment furloughed, and they've been offering tea and sympathy in the wellbeing areas as well.
Perfect. So Joe, if any trust would like to have that service from the airlines, how can they go ahead with that? Who they can contact?
I can send a link to you to a name. It's Captain, I can't remember his surname, it's Captain Dave someone. He's a BA, he's captain of BA, but it's not a BA initiative, it's for any British-based airlines.
Perfect. Yes, please, Joe. If you can send to me or post on the forum so everyone can see it, that'd be great. So let me just. I'm just reading a comment for Amanda here. Okay. So Amanda just wants to say that like her trust has been asked to provide volunteers to be part of their wellbeing hubs for staff, to provide refreshments alongside qualified staff who were able to give psychology support. That's amazing. We had them ready to do and then told not needed, as this one being done by redeployed staff. So sorry to hear that, Amanda. So I think we are conscious that we're running out of time now. I'm sure there were loads of questions for Joe, Emma. Please feel free to send them to me and I can send them to them, or you can post on forums as well. I think that's it for me. I don't know if Sally would like to say something. We can give Sally a try. Sally, do you want to unmute yourself? Give me a second. Do you want to say something? Sorry, I'm afraid you're still muting yourself. There you go. Want to say something? I'm so sorry, Sally. We can't hear you. Very, very sorry for to everyone. difficulty here today, but I'm so grateful that you've joined us, and I hope you found it very useful. And I think we just want to say thank you to Joe and Emma as well.
Hi, can you hear me now?
I'm so sorry, the light is not great.
Yeah, I'm really sorry.
Very, very sorry, everyone. But that's it. So thank you everyone for joining us. We're gonna have another webinar tomorrow to talk about the plan for after COVID-19. It would be great if you can all join us. That's it for now. Well, thank you all and have a lovely afternoon.
Thank you very much. Thank you. Sorry I couldn't hear Sally, but thank you. It's excellent. All the best. Bye.
Bye. Bye.
Bye.